All right, thank you, everyone. We just wanted to double check real quick to make sure all of our attendees were able to join us for this episode. Greetings from Iowa City. Thank you for attending this episode of Chat from the Old Cap, discussing AI's impact on healthcare. My name is Molly Torsha, and I'm the Associate Director of Alumni Engagement at the University of Iowa Center for Advancement. Our host today is Milan Sanka, who is the Director of the Iowa Initiative of Artificial Intelligence and Professor of Electrical and Computer Engineering at the University of Iowa College of Engineering. Milan, I'll pass it over to you.
Thank you, Molly. So, good afternoon, everybody. We have a great group of panelists today. Each of them is an active researcher in the artificial intelligence field as applies to the healthcare. And at this point, I would like to ask our three panelists to introduce themselves and tell us a little bit why they chose to work for the University of Iowa. Loris, would you like to start?
Yes, my name is Loris Couch, and it's been a real blessing to be in Iowa City for the last 24 years. I came to the University of Iowa because it offered an opportunity for me to work both as a physician as well as an ethicist. And so I've been able to integrate ethics and medicine in healthcare together, both in research and teaching and patient care. So it's a pleasure to be with you all today.
Dr. Kajin, thank you. So now the next one, Dr. Lindsay Gnake.
This is Lindsay Knake. So I was actually a medical student here at the University of Iowa, and I studied biomedical engineering before that. But I left to complete my pediatric residency and fellowship in neonatology, meaning I'm a intensive care doctor who takes care of babies, neonates in the NICU. And I was recruited back here to the University of Iowa because of all the amazing work that we're doing and growing in the area of informatics and artificial intelligence. So I was recruited back here as a neonatologist, but I also have a role as an associate chief health information officer within the University of Iowa, where we can help make the decisions, and physicians helping to make the decisions of what new technology should we pursue and integrate into some of the clinical care. So it was a great opportunity to continue doing research and great clinical care, as well as advancing this field in this area.
Well, thank you very much. And last but not least, Dr. Lemuel Nunn.
Yes, hi everybody. I am Lemuel Nunn. So I'm from the Division of Infectious Disease, Department of Internal Medicine. My clinical focus is actually in transplant infectious disease, but like many of us here, I've been captivated by the potentials of generative artificial intelligence chatbots. So my research and my writing for the past year has been about several use cases of generative AI chatbots in medicine, and in particular in infectious disease. Why Iowa? Well, my wife is to be blamed for that. She's one of the transplant cardiologists, so she moved here first, and I followed her a year later in 2019, and we have stayed because of the very family-friendly and scholarly community.
Well, thank you so much. So, Iowa is a great place for interdisciplinary research, and the topic of today's chat is very much, along the lines of that. And, UI Healthcare is a leader in many different directions, and artificial intelligence is an area which is upcoming, which is likely going to change the society, change healthcare, change many aspects of our lives. Can you tell me, starting with any of you who would like to speak first, can you tell me how the artificial intelligence is likely to change the way how it will transform the healthcare? How is it being explored in medicine? How is it impacting your everyday clinical work, research work, and how is it going to change that in the years to come? Who would like to start answering that question? Dr. Gnake, do you like to be the first?
Yes, I'm happy to be the first. So obviously with my background in biomedical engineering, I was always interested in technology, but really, I think that used to be device technology, right? It used to be a lot of what kind of medical devices are going to change medicine and how that's going forward. But I think in this new area of artificial intelligence, which can really be bring a big umbrella term that can include device technology, but it can include a lot of computer programming and algorithms. It's really exciting to see where we can take the big data that we're generating in the healthcare system all the time. Now that all of our data is electronic and in the electronic medical record system, we're generating more amounts of data than we ever have before. So what can the algorithms do with this amount of big data that will help us with the medical decision making in the future? And I think anyone who's interacted with medicine knows that us as humans, we're not perfect in making medical decision making. So it's going to be a really exciting time to see how medicine is going to transform and change, and how can some of these technologies help us in medical decision making, or other different ways that I think probably some of the other panelists can talk about as well, as in note writing or other efficiencies in healthcare too.
Thank you so much. Dr. Nan, you mentioned the generative AI already, and Dr. Knaik mentioned the big data and the many different data sets which include medical records. How does that combine together, and how do you expect that to change your everyday work and everyday clinical care?
Yeah, so let me first start by defining what generative AI is. So it is, an advanced type of AI that is able to generate content based on the data that they were trained on. So we have these large language models, based chatbots that are able to generate lots of information for like many of us. So from my perspective, and I've been writing about this, you can technically use any of the generative AI chatbots out there for note writing, data summarization, because it's able to generate content. You can also use it for many areas in medicine as well, like in medical education. If you're learning about, coding and programming, I think these generative AI chatbots are a good tool to help you with that as well. It has also been explored in some areas in medicine, like in the diagnosis of rare medical conditions. There was this headline a couple of months ago about a patient who has been having these symptoms for like several years, and they asked a question in ChatGPT, and ChatGPT was able to find the diagnosis for them. So that could really open a lot of opportunities, not just for healthcare providers, but for patients as well, to improve their care.
Thank you. And Dr. Dodgin, we heard about the data, we heard about the types of AI that are being used. How is your work contributing to all that's happening at the high level here?
The potential for AI, as we listen to people like Dr. Knaik and Dr. Nan, and you read the literature, it's so vast in terms of all of the different ways in which computers and technology can be used to manage everything from decision making, like Dr. Knaik was talking about, to communications that Dr. Nan was talking about, as well as diagnostics, as well as decreasing what I think for a lot, especially primary care physicians, the biggest burden is the time it takes to satisfy, shall we say, the documentation needs of healthcare, which is very administrative, often very heavily bureaucratic, and often very much related to the way that reimbursement works in terms of having to document those things. So if you were to ask many physicians what they would like to see from this, they would like to say, hey, if you could take care of my documentation needs, that would be wonderful. And so that, I think, is just a very straightforward sort of understanding about how things could be improved if it's reliable and safe and secure and all that sort of thing. But I think what many of us wonder about, especially from the ethics side, is to what extent will we rely upon the appearance of human-like features like language, where there really is no mind. There's no actual intelligence behind artificial intelligence, right? It's actually just this amazing ability to construct things we call sentences by following one word after another. But there is only a meaning there because we already understand what meaning to put onto it. So the whole question of what the human side of all this will be, what the meaning will be, what the values will be, is what I hope we will also spend some time reflecting on here today.
Absolutely. Thank you so much. So we heard about the generative AI. The AI can be really divided into maybe two large directions. One is the analytical AI, the second is the generative AI. So if the question being asked in the healthcare perhaps is, what is the prognosis of some specific drug working for a specific patient, you may combine data from electronic medical records, and you may ask the question how to classify the outcome into fully cured, partly cured, or something like that. And that is part of the analytical classification-based artificial intelligence. And what we hear about much more these days is the generative AI, which we are mostly talking about or have been talking about today. So let's understand those two different aspects of artificial intelligence. One thing which I would like to mention to the audience is that we have the question and answer option for you. So please feel free to type your questions into the Q&A area, which should be appearing on your screen or available on your screen. And we will, in the end, try to get to some of them or most of them based on how many we get and answer your questions if possible. For now, let me continue with looking at software platforms and electronic medical records, because this is something what is clearly important. University of Iowa Healthcare is one of the nation's first hospitals that piloted an AI-driven software platform for electronic medical records and to deal with the overload of physicians' work with electronic medical records. Who can provide some examples how AI can potentially reduce this administrative burden which Dr. Kargin was talking about? How can you spend more time with patients and less time writing the clinical notes? Do you already have some practical examples how this thing works or does not?
Yeah, I can probably start. So I'm gonna, I guess, from the perspective of a user of, generative AI chatbots, you can technically use any of these generative AI chatbots to help you with your notes, right? They can, capture information and help you make notes, help you summarize a lot of information. But many of these chatbots, I have to say, are not HIPAA compliant. So I would not advise just using these AI chatbots for your note writing. There are HIPAA compliant AI tools, however. In fact, a couple of months ago, UAHC had piloted several voice capturing Gen AI tools. I was one of the participants, and I agree that it was really very helpful. I spent more time facing and talking to the patient rather than using the computer to capture information. So I think that's one key area. Personally, I've used, ChatGPT and Copilot in generating patient handouts. Some topics are just not available in the database in our electronic health records, and I just, wrote a good prompt for the chatbot, and it was able to generate me a very patient-friendly information on some complex medical condition. So that's another use case that I found. I've also used it to help make a case-based curriculum for one of the surgeons here in the hospital. You can use it to help with medical education as well. So you can create test questions, right? So I think those are just some examples that I could think of that I have personally have had first-hand experience in dealing with.
Just a follow-up question here.
Go ahead.
Can I have a quick follow-up question? If you would estimate how much time in the pre-AI era you spent on writing clinical notes a day, how much do you think it's possible to be today, and what do you expect down the road, Dr. Nahn?
Yeah, I'm not really sure, but I would estimate that maybe 30 to 40% of my time is probably spent on doing administrative work. Not just in note writing, but also in dealing with insurance companies, writing letters to these companies, Yeah, and with that experience with that Gen AI tool, I think that that amount of time will probably be a lot less. Hopefully, like half of that time would be unburdened from me with these Gen AI tools. Yeah. Mhm.
That's certainly specific and very, very substantial saving. Dr. Nick.
Comment on your follow-up question is, the literature hasn't shown yet that we've reduced a ton of time for doctors' notes, because I think physicians are getting used to this new technology. They have to get used to the slightly different style potentially that the generative AI is providing them. But I agree that I think hopefully over time, as people get used to it, and as the algorithms get better, the more we use it, the algorithms will get better and potentially learn how different physicians like to use their generative AI tools. Hopefully they'll get more personalized and continue to save time for the physicians. So from the administrative side of things, I did just want to say that I'm glad Dr. Nan was able to participate in the pilot. But the University of Iowa is going to move forward with getting a form of generative AI for some of their clinicians. A new term to introduce to people listening is ambient AI, ambient technology. So this is the technology where you might have a phone or a medical device listening to your conversation. And then that is what is going to be generating the note for the clinicians to review and sign in the background. So many places across the country are starting to explore and use these technologies. It will definitely still be in the pilot phase for a while, as in, I don't want people to expect that every doctor appointment they go to that somebody's going to be listening to them and writing notes. It'll be different clinicians who they think it'll work well for their workflow and are used to this technology will be adopting it and trialing it. But it will be really exciting to see how it'll improve that patient interaction over time, because clinicians, instead of looking at the computer, can hopefully interact with patients a little bit more. So I think lots of exciting things to change for clinical care, clinical side of things. But also I wanted to comment a little bit on the research side of things, because some of where I found that these generative AI tools such as ChatGPT or other chatbots like that, it's actually saved me time on the research side of things, because I don't put patient information in there. But if I'm writing a research paper and I want to say, how can I summarize this better? How can I rephrase something better? It saves me time on that, or giving me ideas of bullet points for a talk or bullet points for a letter of recommendation. That is where it can also really help on the administrative side of things and save us time as physicians, so that we could spend more of our time for patient care or more in-depth research, instead of trying to find the perfect word to use when you have that word block and you can't think of what to say.
Thank you. And perhaps a question to Dr. Khalgin here, from the ethical aspects of things. We know that journals require to, talk about whether any tools, AI tools were used, that grant agencies are not allowing that. Now, patients should be probably informed about AI use. What kind of ethical issues is all what we just talked about opening, and what needs to be solved?
Yeah, the ethics is really profound, actually, and it's profound in many different ways, specific to the context of what use the technology has. I think there are many people who would say, hey, if this generative AI can help Dr. Nan document his patient encounters more efficiently and be more natural and human when he's with his patients face to face, wonderful. More power to everyone, and let's pay the corporations all their profit margins that they're seeking to develop these technologies. There's a comma then. If it's safe and secure and there aren't downsides that are unintended. So I think there are certainly some patients who, if they walk into a doctor's office room or clinic room and they see that recording device and they're told, well, this is being recorded, it's going to some cloud somewhere, and it meets our security provisions and needs, and it's HIPAA compliant. How many people in our society say, oh, wonderful, I trust that? As opposed to, I would rather not have one more place in the electronic cloud world out there that has my personally identifiable information that could get hacked by someone. So I think there are going to be some real differences, not only among clinicians and what clinicians are comfortable using, but also what patients are comfortable engaging. And then, so it raises then the question of informed consent. Will patients be given the choice, the genuine choice to say, hey, if the doctor says, I would like to use this technology, is that all right with you? And if the patient says, no, thank you, how much courtesy is shown to that patient to accommodate their preference in that regard. So that would be one example, but we could talk about certainly others. And you let me know if you'd like me to go on about the decision-making side, because I think that's where it gets even more profound, actually.
Why don't you?
Okay, and so on the decision-making, so let's take something like intensive care and end-of-life decision-making. Let's say that AI now it comes up with technologies, and to some extent we already have them, right? We have algorithms that use scales and scores to try to predict the future and prognosticate about who's more likely to die, who's less likely to die, et cetera, and therefore whether life-sustaining treatments are to be recommended. Well, what are the values that go into those algorithms to decide whether, for instance, it's more important to prolong someone's life, even at great suffering, or to decrease suffering but have a shorter life? Those are value-based decisions. Those are not scientific observations. Science will not answer those questions. Human beings add value to these algorithms. And as I read some of the literature, and my colleagues know much more about these things than I do, but in our major medical journals, we're already getting these nice review articles that tell us that the way these language models and these decision-making algorithms are trained is there's both a general and a specific process. And there's a fine-tuning that goes on that actually involves human beings who are paid to steer the algorithms in certain directions. So we might ask ourselves, who's sitting in the driver's seat of that steering? And what are their values? How representative are they of a general population? But more importantly, maybe it doesn't matter to me as one individual patient what the general population thinks, whatever that means. Maybe what matters to me is who I am and what my particular beliefs and values and goals are. And will my physician or my nurse take me seriously as an individual, or are they just going to put me through this thing called the homogenization of a huge data model that gives one size fits all regardless of who I am as an individual?
Thank you. Clearly complex questions and unclear, not black and white answers, which are ahead of us. Let me use this as a segue to actually asking about, practical experiences with using medical data for decision making, and what are the potentials of improving the decision making on the clinical side? How can we get a faster, more precise diagnosis? And I would like to ask Dr. Kneik, you mentioned that you study biomedical engineering, and I know that you have been working in neonatal care, predicting, extubation, how to help, those very, very little ones who are sick and need to be either extubated or not. Would you like to talk a little bit about that particular project and tell us from your perspective, how is the AI, what is the potential of AI of helping to improve the survival and the healthcare outcomes for those premature babies you are taking care of?
Yeah, no, I'd love to. So taking a step back, as we talked about, artificial intelligence has actually been integrated in healthcare more than we've realized for a number of years. Things like automated EKG readings, right? When the physicians get a printout of this. And I realized as a trainee that a lot of the ventilators we're using already have algorithms in it that is helping to improve the care of our patients. So even though we haven't been talking about it as much in medicine, AI has really, there's been algorithms under the surface of many of our medical devices that are helping physicians make the medical decision making. But we still, as physicians, have the power to override that at any point in time in the ventilators we use and the machines we use. So the next step is really, how do we make that next leap in the medical decision making of when can I take my patient off the ventilator? And as an ICU doctor, specifically working with babies with premature neonates, this is actually a very difficult decision to make, because you're not only waiting for the baby's lungs to become healthy again because they were born immature and they have to become healthy, but their respiratory drive actually has to be mature enough so that when you take them off the ventilator, they remember to breathe, they're strong enough to breathe, they can breathe appropriately. So there's many different factors that go into that. And historically, it's been based on clinician expertise and judgment. And again, as we know as humans, we don't always get it correct. And the literature has shown that 20 to 40% of the time, depending on which papers you look at, babies who are taken off the ventilator fail and have to go back on the ventilator, which is very stressful for families, for the babies. And so my hope is in this new age of artificial intelligence and using big data that we can actually create algorithms to help clinicians get more confidence in their medical decision making. Not to replace my medical decision making as a physician, but if I have more objective data saying today your patient has this amount of success rate in coming off the ventilator, maybe I'll be pushed to take my patient off sooner. Or otherwise, maybe the algorithms are picking up on some subtle findings that I as a clinician didn't realize, and today is not a good day to try to take my baby off the ventilator. So some of what we're doing at the University of Iowa is we've written a number of different research grants on this topic and had some success in local funding. And our hope is to get national funding to start doing this at the University of Iowa. And we'll start doing this by collecting data that clinicians can't easily manage in our brains. And I say that as a physician that loves a large amount of data. But standing at the bedside of a critically ill patient, people have seen all the monitors, all the ventilators, all the data being collected maybe by the patient's movements. There's a large amount of data that's being collected that I can't analyze. Oh, the slight variations in the heart rate might mean that this patient isn't ready or this patient's getting sick. So that's what the hope that using math and machines that might be better on picking up on those subtle findings could actually aid clinicians, not replace clinicians, but aid clinicians in their medical decision making. But to kind of talk to one of the questions that was in the Q&A is, it's very important that clinicians work with the developers of this artificial intelligence to make sure we are including the correct patient population, to make sure that we're not causing more disparities or more issues in any of these algorithms we create. But to do that, that's why we request national funding, because we do need larger databases and multi-center databases to make sure that we incorporate kind of a vast array of different types of patients and don't create any algorithms that could cause more disparities or more issues in medicine. But that's why I think it's really important that clinicians who understand informatics are involved in the beginning of the development of these algorithms and stay involved throughout, so we can help make sure that is the case and we're providing the best care we can possible for our patients.
Maybe a quick follow-up question. You mentioned data and many different sources of data that come to, your mind, your brain to make a decision based on. What do you think is, the subset of such data which is most difficult for a physician to deal with, and maybe easier for the machine to deal with, so that the resulting decision making is actually better, faster, more accurate?
So in the research I do, I know a lot of people are trying to use just electronic health record system data or just maybe insurance claims data to make predictions on. But in my opinion, that's data that's already generated by clinicians, and we put that information into the electronic health record. So the kind of information that I think AI will make the biggest impact on are things that it's really difficult for me as a human to understand. And I make that example of heart rate. The heart rate of a baby is changing over time. If anyone's delivered a baby, it can start at 150, 180, and then come down to the normal resting heart rate of adults as the baby grows and changes and matures. So there's a lot of complexity in that heart rate that's changing. The same with how the baby is breathing, the same with the pulse ox waveform, so the oxygen saturation waveform on the monitors. So that's all data that I think that the machine learning algorithms might be able to pick up on subtle findings that we can't as clinicians. And other examples on that could be imaging data, or because the pixels, the different shades of gray as humans, it might be harder for us to pick up on, but mathematically the machines can actually pick up on imaging data or pixels potentially better than we can. So there's many different types of examples like that in the big data that we're generating.
Thank you. I think this is a great example of how your biomedical engineering background and the understanding of signal processing and the interdisciplinary collaboration, which are so good at Iowa, how they actually can help the healthcare down the road. Let me turn attention to Dr. Non's work and Dr. Non's research. You have a lot of experience with generative AI. You mentioned some of that already. What do you expect as your research, question in the generative AI ChatGPT, which would be FDA compliant direction, is going to be most research area down the road at Iowa?
Sorry, can you repeat the question again?
I'm saying, what do you expect from the generative AI chat bot work that will be perhaps most prominent in Iowa in the next 3 to 5 years?
Oh, that's hard to predict. I'm not entirely sure about that.
So what do you expect that your work will be, affected by them?
Yeah, so I mean, my current work right now is on the use of generative artificial intelligence in infectious diseases. So right now we're trying to see if we can improve the accuracy of generative artificial intelligence chatbots in interpreting antibiotic resistance. So that will help doctors out there or other providers who have no access to infectious disease providers make decisions on antibiotic therapy. So our research right now is trying to improve this accuracy by training it with the right information. As to where as to what other areas this could be, Gen AI could be applied in the next few years. I mean, it's pretty expansive what it can do. That's just one thing. Recently, ChatGPT and many other commercial chatbots have expanded to become a multimodal chatbot, which means that in addition to being just a text-based input-output AI platform, it's now able to take in other types of inputs as well. Pictures, videos, audio recordings. So I think there's going to be a lot of movement in this space, and I think the potentials for using Gen AI in medicine is quite limitless, to be honest. In terms of where the FDA is in all of this right now, so FDA was tasked through that executive order by the Biden administration to oversee implementation of these AI tools. And as I think they had released a draft of their regulations and policies this week, or maybe it was last week, for voting. So there's going to be a lot of regulations coming from these federal agencies in the upcoming weeks to months, I think.
Thank you so much. So let's move a little bit from the what can be done, how can it be done, is to a question of how things should be done so that they are done properly. And we already learned and heard about many ethical considerations that are being dealt with in healthcare. And we need to ensure patient privacy. We need to ensure that the data we heard about, the training of AI systems on large data sets, that the data which we are using for training are properly acquired and used properly. Dr. Karjin, would you tell us a little bit more about what are all the ethical aspects that need to be considered when forming training data sets, when dealing with new tools? How can physicians adopt the right thing, and how can perhaps the federal agencies allow to adopt the right things? Because that will be critical as well.
Thank you. You know, the key word that tends to be used is bias, right? We're trying to avoid biasing data sets that would basically give advantages to some groups of people over other groups of people. And that's already a point of discussion in society and including it in healthcare. And so in one sense, it's a recurring theme based on the human risk of injustices based on human nature. So bias and being fair and being even-handed is really important. There are also, of course, then the security concerns. I've read comments in the literature about how even something like a ChatGPT can get poisoned. People can hack into these data networks in order to inject false information simply to cause trouble for people. So how secure are these systems? Then there's the privacy security question, the HIPAA, the privacy that's taken so seriously by our hospital and all hospitals in this country and has very strong federal regulations about protecting patient information that's identifiable. I think there's the question of trust comes up, and I've read some interesting commentaries about how, well, people would say, well, you can or you cannot trust AI, and others would say, actually, you don't trust a computer, you trust a human being. So what is trustworthiness, and where does trustworthiness live? Right? Those are really interesting big questions. And there's also this in the sense of accountability and responsibility, which comes along with trust and trustworthiness. So if AI makes a mistake and somebody is harmed in healthcare, who pays the price? Is it the company that made the algorithm? Is it the physician who used the algorithm? Society is going to have to work that out. There's one last thing I'll say, and I'd be curious to know regarding what Dr. Koenig was saying in this regard, is that there's also something called explainability, and that for certain types of AI, there's this sense, not the sense of which, there is this admission that it's not possible to determine how generative forms of AI actually come up with their outputs, because tens of billions of data points are in the mix. And as anyone who apparently uses ChatGPT, I have avoided doing so to this point in time myself, but you can get different responses depending upon when you put in the query, right? And so the explainability question, it's one thing to say that if I'm using an algorithm, say if I were caring for a patient in primary care who's at a risk of a heart attack or a stroke in the future, and I use a cardiovascular risk score, and I plug in data points, 4, 5, 6 different data points, and I say, sir, you're at a 13% risk of a major cardiovascular event in the next 10 years. If my patient says, well, Dr. Karjin, how do you know that? I'd say, well, here's the calculator. I just plugged in these 4, 5, or 6 data points, and I got this number based on these published accounts in esteemed, reputable journals in this country, etc. I can explain that conclusion on that basis. What I would wonder about, Dr. Koenig, if you want to comment on this, is it sounds to me that my guess is the kinds of algorithms you're talking about are still explainable. It hasn't gone to the step of the black box where, well, we kind of trust it because it seems to work based on clinical studies, but we're not sure exactly how it works. What would you say to that?
So I think we're still evaluating that as clinicians, right? Because some of the examples of explainable algorithms that we talk about are things that we already use today, like logistic regression algorithms, which is more basic statistics, but that's the beginnings of predictive modeling and giving us answers. So a lot of times clinicians use that and are able to understand that a little bit better because that's what we've traditionally been trained. However, as the more advanced algorithms come out, what's hard is why they might not be as easily understandable because they didn't make it into our medical school curriculum. They didn't make it into our undergrad training, right? Clinicians are having to learn this a little bit on the fly. But I think the most important part is no clinician is going to be blindly accepting what the algorithm is telling them until we have some actual proof that it is, getting the outcomes we expect. So I think that's some of what the FDA regulation will be releasing is these algorithms can't go live into clinical care until we've had good studies and proof that they aren't causing harm, they're doing what we expect, but also that clinicians are willing to use it. So I think that'll be a whole nother aspect of research that those of us starting now can get into is the implementation science side of things and how are clinicians going to accept algorithms and will they accept some better than others based on the information that's provided back to them. So I think right now people are developing all different kinds of algorithms, the more explainable kind and the more black box, less explainable, but not many of the black box ones have made it into clinical care because of exactly what you pointed out, is that clinicians are wary of them and not wanting to use them as of yet.
Well, thanks. Yes, quickly getting to end of this discussion, of this chat. But before we get to the questions and from the audience, let me ask all three of you one overarching question. AI, as we already mentioned, and we know, is going to change. The society, change healthcare, change the way how you are going to work in clinical care. How do you expect your role to change? What do you expect the opportunities and the challenges are going to bring in the next 5 to 10 years, perhaps, or maybe even a shorter period of time as a result of AI tools and AI approaches and being available to you on the clinical care side? Who wants to start?
Yeah, I can probably start. So, healthcare is one of the most high burnout domains out there, right? So I think the biggest opportunity is for AI to help us unburden ourselves from all these different administrative tasks. So that's where I'm most looking forward to with when it comes to AI. In terms of how I see AI changing our roles in healthcare, I think it is quite inevitable that AI will become more and more integrated into the healthcare ecosystem. And I think that healthcare providers who know how to use AI will likely outcompete and outlast those who don't. I think one big opportunity for all of us here is to learn more about prompt engineering. It's it's the art and science of crafting prompt inputs into these generative AI chatbots. I think that'll be a handy skill to have, especially when these Gen AI tools become more and more integrated into the healthcare ecosystem.
Somebody else?
Yeah, so I can go next. I think more immediately, I'm going to see from my side on the critical care side is more the other administrative and research things that I do. That the generative AI and these technologies are already helping me be more efficient in my research and teaching and responding to emails and things like that. But I think the long-term one of what more objective data can the algorithms and computer system give us to help us with our clinical decision making, that will take longer to be incorporated into the clinical care as it should, because we want to make sure it's not harming patients and it's including the appropriate amount of patients. So I think that will take longer to integrate into clinical care, but I'm hopeful we'll have more objective data. And it's not because just of clinical expertise. And I feel like I have a good feeling about this patient today that we're making these medical decision making, that we have more information to make those decisions on. But I think that regardless of clinicians becoming involved and using these algorithms, companies will start creating these algorithms and, providing these products, which is why I think it's really important University of Iowa as a large academic research institution start driving some of these are the questions we need to ask, and this is the research we need to do to make sure it's trustworthy before we're going to adopt something from a third-party company or from somewhere else. So been really impressed with how the university has been handling that in evaluating different AI technologies.
And if I could just chime in and say that the basic question that is on my mind, because there's no question about, and Dr. Knecht used the word efficient. Efficiency, I think, is so often the driver. And of course, in a capitalist society, the profit motive that drives creativity and innovation and all that. So there are a lot of drivers to move this sort of thing forward. In the healthcare context, what I wonder about is, will these technologies actually bring human beings closer together, or will it actually create even more distance? So each one of us can wonder about, how are our cell phones affecting our lives? Are they bringing us closer to other human beings or further away? I think it depends. Depends upon each one of us and how we use these technologies. The electronic health record, how many patients have had the experience of walking into a clinic room and wondering if the doctor is ever going to look at them instead of the computer, right? So if AI can actually free up clinicians to spend more face-to-face time with patients, wonderful. If that's genuine and sincere, if it can actually help them attend to the patient as a person, then I think we can all be grateful. But if it does something else, I guess we shouldn't be too surprised, because technology sometimes brings on its own imperatives and its own unintended consequences.
Well, thank you. I think it was very interesting to hear from the mix of clinicians, researchers, as well as ethicists to see how things are going to be approached and what kind of challenges we all have. Let me turn to questions from the audience, and I think that one is very much a follow-up to what we were talking about. I have a question here. How much can one trust AI over a human interpretation? When should AI or the human judgment be given priority? AI hallucinations versus less human access to data. What is important here? We know that the physicians are not 100% correct. AI systems are not 100% correct. So this is an important question. How much should we trust AI, and when should humans be preferred to the AI, or vice versa? Who wants to talk about it?
I guess I can start. I don't think we can fully trust AI. I mean, from the Gen AI perspective, I don't think that we should, 100% rely on these generative AI chatbots to make decisions for us. I think that the best model would be that of a co-pilot one, where humans and AI should work together, should steer this technology together. I don't think that anyone should be using these AI chatbots if you cannot confirm, if you cannot verify the information that's been generated by the chatbot. So I think that's my take on it. I don't think that we should, and I think that it should be a co-pilot model altogether.
Dr. Knecht?
I agree. I would say the term that a lot of people use is augmented intelligence instead of artificial intelligence, right? It's not replacing the clinicians, but helping us in our medical decision making, because we do have to have these checks and balances, and making sure that if something seems way out of left field, maybe something went wrong with the algorithm, and we have that human check as well.
Yes, and I would just like to add, there was a question about hallucinations. So just for everybody, a hallucination is, basically wrong information that's made to pass as real information, right? And I think if I'm not mistaken, and our Dr. Kinney or Dr. Sonka can correct me, but I think this is just an artifact of the Gen AI platform, and it's expected to be less and less as these large language models are trained on more data, if I'm not mistaken. So I think that the newer large language models are expected to have fewer of these hallucinations. And there are some prompt engineering tips as well that you can use in order to avoid generating these hallucinations. So.
Right. I mean, from the technical perspective, those models, ChatGPT or GPT-4, is now based on about 175 billion different weights, which are being combined to get to the proper answer of generating the next token, the next word in the response. We need to understand that if we are prompting those systems to give us an answer, it's a system. It will give us an answer. If it doesn't know, it will still give us an answer, which is in its mind, the most likely correct answer, but it doesn't have to be a correct answer. So as Dr. Nan says, the hallucination hopefully will go away or mostly go away, and it's important to have the human common sense in the loop. I think that is critical. Let me turn to a question which is closely related. What benchmarks exist for evaluating artificial intelligence and machine learning models if they apply to healthcare? How are the models validated? When do they cross the threshold of being useful, and when should we reject them?
So I guess I can start talking about this is from like a more statistical side of things. In medicine, we're taught about things like sensitivity, specificity, which is what all of our laboratory tests are evaluated on as well. And in a big population, we know that even the laboratory tests don't get everything perfect every single part of the time, right? So we're trying to benchmark some of the artificial intelligence off of what historically we've done in other places in healthcare. But it is hard because you have to remember that they're humans, right? So when the artificial intelligence doesn't get it right 100% of the time, do we throw it away and give it up and say this is useless? Or do we say it gets it right most of the time and it gets it right more than humans? So maybe this is something we should continue to move forward with. But I think this is something else that we're learning as a healthcare society of what is our threshold for better than what we're doing right now. And I think generally that's the idea, is the technology going to improve what is the current baseline? But maybe it won't get it 100% because unfortunately none of our medical tests really get things 100% correct all the time.
Right, and another important aspect here is that even that comparison, getting it right, is based on the truth or truth in quotes, which we may not always be sure that it's actually correct what we think is correct, and so it's making that question even more complicated. Let me turn attention to one last question which we had from the chat audience here. And this may be a question for each of you to answer. Where do you see the greatest immediate impact of AI on UI healthcare, patient care, teaching, or research? Do you think it will be in the patient care, it will be in teaching, it will be in research? Where do you think the AI will affect us all most in the next few years? Dr. Nan, what do you think?
Yeah, I think it really depends on what you do on a daily basis. So, I mean, for me, I'm a I'm a clinician, so I would expect, or at least I would anticipate that these AI tools would help me in delivering effective patient care. The fact that there are Gen AI tools out there that can help me with administrative tasks, then that means that I will have more time with my patients face to face. So that's one aspect. And then, I mean, I also do some teaching and some research, and there are some AI tools out there that can help me do both. So I think it really depends on what you do. And yeah, and if you try these Gen AI tools, I'm sure that you'll find something that can work for you. But yeah, make sure that it is compliant to our uh, systems. We have a web page. It's called Assess Technology, where you can see if that Gen AI tool that you're using has been assessed by the university and whether you can use it. So, yeah.
Okay. Dr. Knaik?
Yeah, I think it's going to change all aspects of patient care, teaching, research at the University of Iowa. But I think one of the things I'm curious to follow over the coming years is how quickly the younger generation is going to pick this up and organically start using it, even if we're not formally teaching it. And as we've talked about with efficiency, being a pediatrician, I know teenagers thrive on finding ways to do things faster and being more efficient. So some of my colleagues have already told me that their 11-year-olds, instead of going to Google to ask it a question, will go to ChatGPT to ask it a question, which right now, we have worries about that and whether they are getting some hallucinations and learning things that aren't correct. But I'm hoping what teachers will teach in their lectures is that you need to evaluate the information you get back and make sure you believe in it and it is correct before you submit that as your final work, so that people learn how to use these technologies and figure out when it's telling you useful information and when maybe it's not.
Thank you. Dr. Kaljin, we have a chance to give the last word here.
Well, it's amazing how many new terms this field introduces to those of us who are more new to it. And one of the terms that I've encountered is the de-skilling. The skillful de-skilling, the de-skilling of the profession or of the professions. And that is a risk that some people talk about and write about, which is to say that we will rely so much upon access to AI that we will cease to use our rational faculties in a regular, rational, critical, self-critical sort of way. And so far we've heard both Dr. Nahn and Dr. Knaik talk about how, well, the doctor has to be judge of the technology, of the tool. The question over time is, will, out of convenience or efficiency or frank laziness, whatever it might be, will people simply rely upon the tool and give up their sense of authority and mastery of the tool?
Well, thank you. I think that this is hopefully not going to happen, at least not at Iowa, because we have physicians who are well educated and well ready for the new AI revolution. I would like to ask all the panelists for contributing today. Thank you so much. And I'm giving control back to Molly Torsha.
Thank you very much. Well, thank you, Milan, and to our UI healthcare experts. This has been a fascinating conversation. And thank you to our attendees for joining us today. We greatly appreciate our alumni, friends, and fans for supporting the incredible work that our UI healthcare team is doing daily for patients worldwide. Thank you and have a great day.